Yep. Okay, so as I said, we're going to give you an update on where we're up to with education. And unfortunately, we can't control the slide, so you'll have to get used to us saying next slide, please. So next slide, please, Francis. So I'm sure a lot of you are familiar with the National Wound Care Strategy, and you know that we are focusing on 3 particular wound types. Surgical wounds, which, as I've said, I lead on, and they account for about 14% of all wounds in the NHS. Lower limb ulcers, which Christian leads on, and they're about 37%, and then pressure ulcers that Jackie Fletcher leads on, but she's off on holiday this week, so we're going to cover those as well. Next, please. So what is the problem and why do we exist? So the reason that we are here and that we're in this position, the main reason is for the increasing burden of wound care is unfortunately unwarranted variation. Too few patients receive evidence-based care. Instead, there's often an over-reliance on dressing products, which often manage the symptoms of wounds, but do not treat the underlying disease process. Too often, wounds are poorly organised, which means there are significant delays in people being able to access care from clinicians with the correct knowledge and skills and time to be able to accurately diagnose and treat the underlying cause. So if the system's not set up to make it easy for the patient or for the clinician either. And unfortunately, there are also issues with data. Very few organisations have symptoms which support them to accurately capture clinical wound care data and information. So many are blind to the scale of their local problem and even on a national scale as well. Of course, that data is pivotal to both informing and sustaining quality improvement. So what are we trying to achieve? Well, we're trying to improve patient care and reduce patient suffering. We're trying to reduce this unnecessary variation. We're trying to improve healing rates and reduce recurrence and make the best use of the limited NHS resources that are available. And hopefully, if we achieve that, then we will also improve practitioner job satisfaction. Next slide, please. So surgical wounds are a very common type of wound in terms of volume. There are lots of surgery, but in terms of most of them heal without complications or delay. But healing is problematic in a significant minority. And delayed wound healing in surgical wounds can be due to either surgical wound dehiscence, so separations of the margins of a closed incision, or due to surgical site infection. And surgical site infection is an infection related to an operative procedure that occurs at or near the surgical incision within 30 days or within 90 days if there is a prosthesis. What we do know is that surgical wound dehiscence increases the risk of surgical site infection and vice versa. So there's not always infection with a dehisced wound, and a surgical site infection will not always lead to dehiscence. And a dehisced surgical incision may or may not display those clinical signs and symptoms of infection. Next slide, please. So what's the scale of the problem? Well, these are purely based on guesstimates. Certainly some of Guest's work suggests that the annual cost to the NHS of managing delayed wound healing in surgical wounds is estimated to between 957 and 985 million. But the scale of the problem is uncertain, as it's unclear how many surgical wounds have delayed healing. And the reason for that is because there's a lack of standardisation for post-discharge data collection. And that's resulted in a limited understanding of delayed healing. And certainly there's an increase since COVID of day case surgery. So many of these patients are being discharged back to community at the point of operation. So we have got no understanding of how much these things happen. So some estimations of surgical site infection from the UK HSA in 2022 suggests it's between 0.4 to 11%. But unfortunately, at the moment, most SSI surveillance ends at hospital discharge. Collection of SSI data in community is not mandatory, and also collection of SSI data is not across all specialities. And then the current estimates from 2018 of surgical wound dehiscence are between 0.4 and 41%, so quite considerable. Next slide, please. So what have we done? Well, back in 2021, I was here, but not officially, and we developed some surgical wound recommendations and tried to address some of this, tried to identify what good looks like, and then develop these evidence-based recommendations. These are, unfortunately, however, now are out of date, so I am here again and hopefully we'll be looking at these. Next slide, please. In terms of our vision, we talk about three key areas. The first are the people that are involved, so the staff, the requirements for those staff to be able to undertake what good looks like, the actual process of the what we're trying to achieve, so looking at clinical pathways, how are we going to improve in things, and then also technology, which obviously looks at digital systems, but also is around the data required to make these changes happen. Next slide, please. So in this webinar, we're only talking about people because we're talking about the education. And when I came in August, we had no resources for surgical wounds or for wound infection. And that's because people have been concentrating on those other areas. So we are in the process of developing some tier 1 resources for essentials of surgical wounds and essentials of wound infection, and some tier 2 resources looking at principles of managing surgical wound complications and managing open surgical wounds, which often is not touched on in terms of education, and also looking at the diagnosing and managing of wound infection. So these are free resources, easy to access on the e-learning for health, and they've been mapped against the core capabilities. Next slide, please. So other resources that are in development, we've got a patient information leaflet on surgical wounds, which is at the design stage, so should be available in the next few months. We're also developing some patient information leaflets on wound infection, and I've just about to send that over to our patient group. And then we're also looking at some information for all of the different wound types on shared care, which will help with our patient cohort. And these leaflets are all being written by the Patient Experience Network, which is a group of patients led by some experienced writers, and they are great at developing their own patient information leaflets written by patients. Next slide, please. So what are our future plans? Well, as I've said, we need to review the surgical wound recommendations, and that's really because we've started to not just talk about surgical wound dehiscence and surgical site infection, but we're talking about that umbrella term of surgical wound complications, which encompasses all of the different reasons why these wounds develop. So in light of that, we need to change the focus of our surgical wound recommendations, and we're just in the process of starting to look at that. From those recommendations and the clinical pathway that comes with it, we will look at developing a preventing surgical wounds care bundle, which we hope will identify aspects of best practice. And then obviously we need to implement both the recommendations and the care bundle once they're fully developed. I'm now going to pass you over to my colleague Krishna, who's going to look at leg and foot wounds.
Thank you, Jackie. So I'm going to be talking specifically about lower limb. So I am going to be talking about leg and foot wounds. And in England, we do know that we've got a huge amount of people who have got foot wounds, lower limb wounds. That includes the leg and the foot. And when we're talking about leg ulceration, we're talking about the vast majority of the leg ulcers are due to venous disease. And unfortunately, we have an issue with delayed rates of healing and high recurrence. When we're talking about foot ulceration, however, we know that there are well-established pathways and services for people with foot ulceration who have got diabetes. However, the number of people who have got foot ulceration who do not have diabetes is at least equivalent to those who do. So the group without diabetes also account for a higher number of amputation. So therefore, whilst the healthcare needs for both these groups are similar, people without diabetes find it difficult to access the care that they need. Next slide, please. So as a programme, the first thing we did in order to try and address this unwarranted variation was to identify the evidence-based recommendations for care. Now, these are currently being updated, and instead of presenting them both under lower limb, they will still be published as lower limb recommendations, but they've actually been split into leg ulcer recommendations and foot ulcer recommendations. The foot ulcer recommendations are currently out to consultation, and I think the deadline for them is tomorrow. So if you do want to input on this, then please do get involved. Go to our website, and the link to the SurveyMonkey is actually on there. And I know, and I want to say thank you to the number of people that did already consult on the lower limb recommendations, and they're currently in the process of being updated. And we're looking around middle of May for both of them to be published. And we'll be doing some webinars as well to support that when we do publish those recommendations. So these recommendations actually look at what good looks like, and we're trying to seek to build and address the gaps in the existing guidance that exist. So the main highlights that I just want to bring is that with the foot pathway, we're looking to bring the pathway for patients with foot ulceration and without diabetes in line with those who have got diabetes. And with leg ulcers, we want to look at starting patients in some form of mild compression in the absence of red flags, ensuring that a holistic assessment is done within 14 days, and then treatment and onward referral to vascular or other services as necessary. So in the case of venous leg ulceration, the treatment being strong compression and further assessment by vascular services for potential venous interventions. We then developed a business case for the case of change, and then we recruited 7 implementation sites. As a learning programme, we're learning from how they have implemented the recommendations locally. Next slide, please. So as my colleague has already said, as a programme, we're using the same framework for each wound type. We're using with people, process and technology. And with people, we know we needed to outline a standard for wound care skills and knowledge and provide high quality education to multi-professional audience and the resources for patients and carers to educate, empower and support that supported self-management. In terms of process, it is about reorganising those clinical pathways, and finally technology to ensure that we are able to capture the clinical, the data captured to support any quality improvement through that data capture, so we are able to see where those improvements need to be made, and where those improvements have been made, what the impact of that has been going forward. Next slide, please. So in 2021, we developed the National Wound Care Core Capabilities Framework, Wound Care Core Capabilities Framework. I know Jackie's touched upon this already, but the framework set out a consistent standard of wound care knowledge and skills across the workforce. It's been designed by a multi-professional team for a multi-professional audience. Next slide, please. And if we look at the structure of the capability framework, it's mapped under 5 domains, and within those 5 domains, there are 12 capabilities. And when we were looking at the development of this core capability framework, we mapped it to a lot of other national capability frameworks and encompassed all that within this particular document here. Next slide, please. And the capability framework is based on a tiering system. So you heard Jackie talk about tier 1, tier 2, tier 3. It's not built on banding. So that's what the difference is with this capability framework. What we're hoping to do is use this capability framework locally to help you identify any gaps in knowledge and skill that may exist, which can then inform the development of learning development and plan for the workforce ahead. Next slide, please. So here we just want to give you some workforce examples. So the core capability framework has informed some additional work that we've done nationally on the tiering system. So what we've done is set out what level of skill and knowledge is required at each stage of the clinical pathway within lower limb care. Based on feedback we've received to date, we recognise that we need to support and further explore how to go about educating the workforce. We're now working on aligning this more tightly to the capabilities framework and expanding it across the wider workforce, which is involved in lower limb care, with pressure ulcers and surgical wounds, and developing recommendations on experiential learning. And my colleague Jackie will talk about this in a little bit more detail, a little bit longer, a little bit further on in this webinar. The additional good news is that with persistence, the importance of wound care education is being recognised, and some of our sites have now been able to get our online resources that we've developed as essential or mandatory within their organisations. Next slide, please. So here you will see how we have mapped the tiering along the lower limb clinical pathway. So at each stage, the knowledge and skills that would be required when delivering care for the lower limb clinical pathway. Next slide, please. So as with surgical wounds, we're a little bit ahead in that we've already developed and already published on the e-learning website the Tier 1 and Tier 2 resources. So we've had some really good updates. Our figures from E-learning for Health shows a good interaction with the actual modules. The majority, we've had very good feedback. And I just want to bring to light that we are in the process of developing a skin and nutrition module, which will be aimed at Tier 1. But we've also got a debridement module and a vascular assessment of the lower limb module, which is going to be slightly different, which will be in a video form, which will go through ABPI, toe pressures, palpation of pulses, history taking, everything in relation to vascular assessment, but in video form. But what we do want to say is that these online resources are just that building block. They should be then substituted with local learning as well, so you can then apply it to practice. Next slide, please. We've also got a whole set of resources, educational resources available on our website. So we've got one on compression therapy, and if you go to the National Wound Care Strategy website under the Education tab, you will see all the different educational, the patient resources that have been developed. But we've also got on our website other resources in regards to lower limbs specifically, in terms of vascular referral forms into vascular services for venous disease and peripheral arterial and chronic limb-threatening ischemia as well. Next slide, please. Thank you. So what have we learned so far? We've learned from the first implementation site that taking a blended approach to training with a combination of online and face-to-face delivery works. And they're doing this right across the workforce for those who are doing any part of wound care as part of their role. They're reporting that the online resources that have been produced in conjunction with Health Education England are providing useful building blocks to complement local practical education sessions. They're a good foundation prior to attending a taught session or developing practical skills by experiential learning. They've also told us that as the National Wound Care Core Capability Framework, which sets out the expected wound care knowledge and skills for all patient-facing practitioners in Tier 3 or levels, is a useful tool to map what skills and knowledge are in the existing workforce, but where the actual gaps are. However, we have had some challenges as well. The challenges being that there are variability in how the wound care core capability framework is being applied locally. And there's differences in the approaches to the experiential learning. And whilst the areas find the resources helpful, there's been a struggle to actually ring fence that time for education. And wound care is often seen as low priority, so local approval to get wound care education resources is essential, can be difficult. Next slide, please. So going forward, I just wanted to give you a little overview of what's going on with the lower limb work stream. We have got the sequin for leg ulcers, which has been republished again for this year, and there are some very helpful resources on our website. The clinical recommendations, as I've already said, have been separated into leg and foot, and they are due to be published with updates in middle of May. We're going to continue as a programme to evaluate our learning with our first implementation sites, and to let you know that our AHSN have taken on the programme as a transforming wound care programme, and will be providing further implementation of recommendations locally. And we're also developing best practice bundles, which will be, we've talked about the recommendations as the what, the best practice bundles will then talk about the how and how to actually implement them locally. Next slide, please. I'm going to pass you back over to Jackie, who's going to go through the pressure ulcer work. You're on mute, Jackie.
I was being good and keeping the dog quiet. Apologies. So pressure ulcers are often an unwanted and often avoidable complication of care. Nationally, the reduction of pressure ulcers is seen as a priority area, with their occurrence being cited within the top 10 harms reported within the National Reporting and Learning System. Next slide, please. So pressure ulcers often result in high medical cost, increased use of antibiotics and analgesia, and place a high burden not only on patients' families, but also on the national health and social care systems. They're a common occurrence and they affect over 700,000 patients a year, particularly those whose mobility is limited due to illness, severe physical disability, or increasing frailty. In older people, they're associated with a 5-fold increase in mortality, with hospital mortality reported at 25 to 35%. They can result in longer lengths of stay in hospital, from an additional 4 days to an additional 10 days for those over 75 years of age. They're associated with a high rate of readmission within 30 days, and emergency readmissions for pressure ulcers almost trebled from 7,700 in 2010-2011 to 22,400 in 2016-17. The increase in the number of patients being readmitted with a pressure ulcer superseded the overall increase in the number of pressure ulcer diagnoses in hospital. That's a massive figure. And it is estimated that their care costs to the NHS in the region are in the region of £571 million per year. Next slide, please. So why are we focusing on prevention? It was a total of 24,389 deaths were attributed to pressure ulcers in 2019, and a total of over 3 million new cases were identified globally in 2019, and these numbers are increasing year on year. Next slide, please. So the pressure ulcer work stream is currently working on a whole range of activities, and obviously I won't be able to go into all of them, but we have the pressure ulcer sequin, we've got some surveillance work, you've heard about some of the e-learning modules, we've got patient and carer resources in development, we've got Stop the Pressure Day this year coming up, where Jackie's also working on a best practice care bundle. The clinical recommendations and clinical pathway are currently out for consultation. So if you haven't seen them yet or commented on them, pop over to the website, and these close on April the 5th. So you've still got time to put some comments in. Also, she's involved in some quality improvement programs, and we're trying to develop an ongoing awareness program like Legs Matter, called Pressure Ulcers Matter. So keep an eye out for these things happening in the future. Next slide, please. So again, following the other work streams, we're looking at people, process and technology in relation to specifically pressure ulcers. And as I've said, we're concentrating on people today. Next slide, please. It's not moved on, sorry guys. That's it.
Moved on at my end. I'll try again. Is it done now?
It's just a delay, sorry about that.
Oh, right,
so we already have a tier 1 resource for pressure ulcers, essentials of pressure ulcers, but we are developing a purpose T risk assessment resource, and we also have the pressure ulcer curriculum. We're also looking at, in relation to the recommendations within the new recommendations, we're looking at amending some of our existing tier 1 resources to reflect those changes within that document. Next slide, please. So there are also some other education resources available. There is a patient information leaflet on pressure ulcer prevention that's currently in development, along with a whole range of other things like what to do once you've got a pressure sore, how do we try and prevent pressure sores, etc. So there is a whole range of these patient information leaflets that will be available in the coming months. Next slide, please. So as I said, Jackie is developing a pressure ulcer best practice bundle. This will fit alongside the recommendations, and once these are both available, then we will be implementing those and hopefully start to see some improvements in care. Next slide, please. So Krishna mentioned earlier the National Wound Care Core Capabilities Framework, and we have started to look at this in relation to what can we recommend for not only theoretical education, so where are the resources which are available, and that's across all the domains, not just the domains for wound assessment, diagnosis, or for wound care. And we're also trying to identify within that what skills are required at each of the tiers across all of those domains. So that is a document that is in quite an advanced state of progress at the moment, and we're working with Skills for Health with that. So hopefully that document will be available in the next couple of months. A more long-term sort of strategy is to look at developing a career framework for wound care practitioners. So we've got a whole host of multi-professional people working together to look at what would this career framework look like. It'll be from bands 2 to 8, so encompassing our non-qualified staff as well. And it will be multi-professional, so it'll be across all disciplines. So this is more of a longer term strategy. I haven't got an idea when this will be available, but it is something that we're working along in the background. I'll now pass it back over to Krishna to just give you some take-home messages. Next slide, please.
Thank you, Jackie. We just wanted to leave you with some take-home messages, really. Do go onto our National Wound Care Strategy Programme website. All the resources that we have talked about today with the links are all available under the different work streams and also under the education work stream. do go have a look at the wound care core capability framework and have a look at it in a little bit more detail. Have a look to see how you may be able to use that to identify, if you're not looking over a team, but perhaps where your own learning gaps may be, to actually help fill and try and address those sorts of gaps that you may address for yourself. Also, go and have a look at the e-learning modules and have a go at them. We've tried to do, we always think of e-learning and we think, oh God, e-learning, but the e-learning modules that have been developed are really interactive as well. We've got the granulation game, which is a complete different way. It's like a game to actually help those who may be a bit more of a visual learner as well. Do have a look at the resources we've got. So the things we've developed are all there to help support not just your learning, but also to help you as practitioners going forward. And given that you're here today, I'm going to make the assumption that you are a stakeholder, but if you're not a stakeholder, then please do log on and join as a stakeholder and be involved in all the work that we are developing, because your voice is really, really important to us going forward. Next slide, please. So here are the details for anyone who does want to connect with us. Our website details, our email address if you do want to email us. We do have a Twitter page, which is NatWoundStrat, and we're also now on LinkedIn as well. So you can connect with us on these social media channels, and we're doing constant updates of the work that we are doing on there. And you can always email through to us on our email address if you do have any questions going forward.